We're delighted today to welcome Dr. Gabby Agin-Liebes. And I hope I pronounced that correctly, Gabby. Who's a clinical psychologist, but really importantly for today's discussion, she spent the last 10 years as a therapist and investigator on psilocybin trials, and recently completed the 4-year follow-up of the end of life use of psilocybin for depression and anxiety. And as people on this call will know, one of the questions that keeps getting raised by people who have doubts about these therapies is, well, you might get large remission rates in trials, but really do they last? So I think that's going to be a really interesting aspect of Gabby's discussion. Before I formally hand over to Gabby, Ilan, have we got some slides?
We do.
Okay. Do you want to go to the next one? Look, just a couple of words. I mean, firstly, it's really important that people realise that we focus on the medicinal use of psychedelics as part of therapy to help people with mental illness, and that we have no interest in, as an organisation, in the psychedelic use of these substances. The second thing, by way of introduction, is that we'd ask people not to record this session, that the session will be available on our website in due course. I'd also like to acknowledge the traditional owners of the land where we meet and pay our respects to elders past, present and emerging. Would like to acknowledge the elders' wisdom, traditions, cultures and communities who have used these medicines for thousands of years for their intelligence, spirituality and their healing potential. So next slide, Lan. I suspect most people on this webinar will understand that Australia is going through a horrible time in terms of what's happening with mental health. We already had, I think, the second worst mental health statistics in the world pre-COVID. And all the evidence says that the levels of mental illness in our society are increasing because of the pandemic. Particularly concerning to me, and I'm sure all of you on the call, is what's happening with antidepressants. We've had this massive increase in antidepressant usage over the last 15 years, up 95%. 1 in 8 Australians pre-COVID, 1 in 4 older Australians, and now 1 in 30 younger people on antidepressants. And yet we're not seeing these terrible mental illness statistics turning around. Those mental illnesses that we've listed down the bottom are there for a reason. Not only are they some of the most significant mental illnesses in Australia, but they just happen to be the mental illnesses that these therapies have been most applied to date. Next, Ilan. Again, one of the points that we keep stressing is that the problem that we have with mental health or mental illness in Australia is not just this whole issue about improving processes and improving efficiencies and generating better patient access gateways. The fundamental problem we have is we have treatments that actually, in many cases and for many people, aren't fit for purpose. Now, when I say that, I'm not in any way disparaging the current treatments, because it's all we have, and they do serve a significant number of people, but the problem is they don't help a large number of other people, and often they can have nasty side effects, as we see with antidepressants, and patients can relapse as soon as the therapies stop. The startling thing about these statistics is that, current modalities are only gaining remissions in about 35% of patients with depression. And when you come down to PTSD, remission rates, we're told by people working in the area, doing research on PTSD, is somewhere between 5 and 10%. So our ability to help people with serious trauma is, unfortunately, because of the current modalities, not that great. So the point down the bottom is that, if we keep going the way we are, we can keep shoving more resources into the sector, but actually, unless we improve the treatments, we're never going to solve this mental health, this crisis in mental health that we have today. Thanks. I think most of you will know, but it's worth saying again that we're a charity, and we're deliberately a charity because we want no vested interests other than getting the very best results in terms of utilising these therapies as part of our medical system. Current focus is very much on psilocybin and MDMA simply because they're the furthest advanced in terms of trials, and we have the most evidence in relation to those two substances. For us, success is very much making these therapies an integral part of our mental health system. We're not in any way trying to get in the way of medical professionals and their patients. We just want our medical professionals and patients to have more options. We'd like to see high remission rates so that we really start to turn around these dreadful mental health statistics. And critically for us, we want these therapies to be accessible and affordable to all Australians in need, irrespective of the wealth of individual Australians and irrespective of geographic location. Next slide, Elaine. I think all on this call will realise that the beauty of these therapies is it's only 2 to 3 sessions with the medicines, that the medicines as part of therapy are curative, not palliative. All the evidence says they're very safe to use in a medically controlled environment and they're not addictive. And both now have breakthrough therapy designation with the US FDA. So things are accelerating in the sector. We might pass on the slide because I suspect everyone's seen it before, Alan, and Gabby, if not, can perhaps refer to it in her presentation. We started My Medicine 2 years ago, and I have to say when we started it started off as slow going because people needed to be convinced that these therapies had to be taken seriously. And Australia was way below North America and the UK in understanding these therapies through trial work. Having said that, over the last 2 years, we really have accelerated as a country. And I think that was emphasised when the government a few weeks ago announced the $15 million grant funding for psychedelic research, which has really got a lot of researchers now focused on this area of treatment for mental illness. We're all about 4 things. Firstly, awareness building and education, which this webinar is part of that. Secondly, the certificate in psychedelic-assisted therapies for therapists, so that we have qualified therapists who can work with psychiatrists and other medical professionals in delivering these therapies. And I should mention there that I'm actually at the moment at Psilocybin College, where we're halfway through the 1-week residential of our first course in psychedelic-assisted therapies with a group of psychiatrists, psychologists, psychotherapists, counsellors, and that first intake graduates in about 2 weeks' time. So very, very exciting. We're putting a lot of work into an Asia Pacific Centre of Excellence, and I'm hopeful that something will be announced on that fairly shortly. And lastly, we're going through all the logistics involved with making these therapies available, including manufacturing and obtaining the medicines, clinic rollout, developing the right protocols, and all the things that actually go from the theory behind these therapies to actually making them available with appropriate regulatory support as part of our medical system. Next slide, Elaine. Look, the last point here we wanted to make is that we are a charity. These webinars are done free of charge because we don't want cost to be an inhibitor of spreading the word. But we would encourage all of you, if you're not a donor to Mind Medicine, please look at our website. Every donation is important to us. It enables us to really leverage up the work that we do. And the more leverage we can gain, I think that the quicker these therapies will be available to patients and their medical professionals to use in medically controlled environments as an alternative to existing modalities. Is that the last slide? Okay. All right. Well, we might take the slides off now, and I'm delighted, Gabby, to again introduce you. Fascinating background, very relevant to to the work that we've been doing, and I think a lot of interest in Australia about not only the ability of these medicines to, as part of therapy, to generate remissions, but also the longevity of the remissions that are achieved and the experience that the patient's going through, which is helping to generate those remissions. As I mentioned in the introduction, Gabby's a clinical psychologist with 10 years as a therapist and an investigator in trials with psilocybin-assisted therapy at New York University, Yale, and UC San Francisco. And obviously directly relevant to today's presentation, Gabby was part of the team that did the 4-year follow-up study in relation to the impact of these therapies for people with end-of-life distress. So Gabby, over to you.
Thank you so much, Peter. And I'm really happy to be here. Happy to see so many people from across the map, so many different all corners of the map, let's just say that. So I'm delighted to be here to talk to you about some work that I've been involved with for many years now, and that is very near and dear and close to my heart. I will be talking about a few one main trial and several follow-up studies from the work that I started at New York University. And then I will talk about some future directions. And as a clinical psychologist, I am very oriented towards understanding mechanisms, psychological mechanisms of change in these interventions. So I will spend some time talking about that, and that's where I've spent most of my research lately, trying to understand these processes, which are unusual types of therapeutic experiences. So as Peter mentioned, I'm currently at UC San Francisco, and I am just going to start off by disclosing some of the funding that I have to support my work. I'm currently on a National Institute of Health fellowship at UCSF, and over the course of my grad school career, I've been supported by a number of private individuals, mostly in foundations, because most of the psychedelic, or at least at this stage, the psychedelic research that's taking place in academic centers is funded by private entities. Okay, so before I jump into the meat of my talk, I wanted to put up this quote by Viktor Frankl, whom I'm sure many of you are familiar with, and potentially this quote, the specific quote. Viktor Frankl was a Holocaust survivor and then went on to develop a branch of psychotherapy called logotherapy, meaning-based psychotherapy, which is quite relevant to the population that I'll be talking about, which is cancer patients struggling with existential distress. But I put up this quote to sort of frame the talk, and also to share that this is was one of the reasons why I was inspired to enter the field. It's the field of psychology. Everything can be taken from a man, but the one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, and to choose one's way. I should have altered that to say to be taken from a man or woman, or non-binary gender in these days. But I do like to reflect on this notion here that we can be victims of circumstances that are of extreme circumstances, adversity, as Viktor Frankl was as a Holocaust survivor, but we're never victims to our own minds, our own hearts, and we always have the power and innate capacity to kind of find our way home and find our own freedom. And I do really think at least the participants in our trial were able to find that freedom. Psychedelics, psilocybin in particularly, helped them to kind of wake up to this realization of this coming home and taking a path, no matter what the circumstances that were out of their control. And actually, I should mention before I go on, I think unless there are burning questions, I think it would be best to save questions for the end. I do see we have, I do love interactive, so maybe what we can do is have questions in the chat, and then if there's a really burning question, maybe you can unmute yourself and interrupt me. But if you think you can wait till the end, because we're going to have time at the end for questions, I think that would be preferable. Does that sound okay? Okay. All right.
Sorry, Gabby, you are coming across as a bit muffled.
A bit muffled? Thank you. Okay. If I hold my mic here, is that better? No?
Still a bit muffled.
Still a bit muffled? Okay. Let me then take myself off. Okay. If I take myself off the mic,
Slightly better.
Can you hear me now? Yeah? Okay. All right. Let me know if I should make any adjustments. All right. So today I'm going to be talking about, as I mentioned, these studies that took place at NYU, and then we'll be, okay, very workable. Okay, great. Thanks for that feedback. So talk about existential distress, limitations of the current available interventions that we have, and then the mechanism that I've been sort of, other people in the field that I've been developing as a possible potential mechanism is this idea that these altered states that are facilitated by psychedelics can promote this way of coping with cancer that enables a person to reappraise the threat and the stress, and then they later increase their sense of meaning in life. So I'm going to propose that, and then I'm going to go into the data. All right, so just a little bit about me. Okay, so is everyone able to hear me okay still? More or less, it's okay. I'll just try to talk really loud and
It's workable.
It's workable? Okay. Sorry about that, everyone. Hopefully my Wi-Fi should be good, so you won't lose me, but I'll try to be very clear and very loud. Okay, so I've been all over at least the continental US. I'm from New York City. I made my way to the Bay Area several years ago and got my degree at Palo Alto University and ended up back for part of my training. So don't want to spend too much time on here, but I've been kind of East Coast, West Coast, and I'm currently at UCSF. And I'm also very committed to equity and inclusion and intersectionality within the psychedelic space. So I'm also a founding member of an organization called Equity and Psychedelic Therapy Initiative that I am working on now. I might have time to tell you more about that at the end. And I want to, I appreciate Peter's acknowledgement as well of the fact that I am on occupied land here in the Bay Area. So I'm not the original custodians of this land, and I want to just pay our respects to this community and give our gratitude to the original owners of this land. All right, so now moving into the topic. Existential distress. So if I could see everyone, I would ask folks to raise their hands. I see a few people on my sidebar, but I'd ask folks to raise their hands to tell me how many of you have been affected by cancer personally or know of someone close to you that has had, okay, I see some hands. Okay, so my guess is that many people have. Yeah, it's really common. I actually didn't know how common it was until, I mean, I knew it was, and I've been working in psycho-oncology for a while, but I actually didn't actually look up the stats. I had to relook, recheck the stats. So 54%, at least in the US, of Americans have themselves or someone they know in their immediate family that's been diagnosed at some point. And cancer will affect 1 in 2 men and 1 in 3 women also at some point in their lives. And by the year 2050, that number is supposed to double. So a lot of people, it's just like a martyr. I mean, it's always been around, but it seems to affect actually developed countries, potentially even more so, or certain types of cancers too. So, and what happens though when cancer diagnosis can provoke, for some people, not everyone, but for some people, it can provoke this type of existential distress that is very hard to treat with our traditional medical interventions that we have available. And from the perspective of this terror management theory, it's a social psychological theory that maybe folks are familiar with, that describes that people, I would say most humans, are innately motivated towards self-preservation and survival, and actively try to avoid reminders of their death. We all are going to die, of course, but we all, we tend to put up sort of barriers so that we're not overwhelmed by this, by this fact that we're going to die. So, but what happens is if we get diagnosed with a cancer, if we receive a cancer diagnosis, that distance shortens, and then it can end up creating a very upsetting, very overwhelming existential type of crisis for folks. So I have some quotes up here from some of the participants in our study whom I interviewed at qualitative interviews, who described this kind of experience when they heard that they were getting diagnosed with cancer. So realize you're going to die, don't know you realize that until you're told. You think you have limited time, and that changes everything. And this conversation is really avoided in medicine. It's just, we don't really talk about death. We don't have good conversations about this. And then there are not many very good treatments. There have been advancements in meaning-based therapies. A lot of it has been done actually at Memorial Sloan Kettering in New York City. Is a very renowned oncology hospital, and they do have a very robust meaning-focused therapy program there. However, there are the evidence of suggesting or signaling their efficacy is relatively weak. And then when it comes to medications, there's really nothing that we have that's going to really just touch this type of distress. It's different than, there's no DSM category for this type of existential malaise. So this is where psilocybin might come in. And there's lots of dropout actually and slow retention. So I'll get back to that in a second, but I'm gonna pause for a moment to talk about how psilocybin and other classic psychedelics might be able to play a role here in alleviating this distress. So there's a very, very long legacy of psychedelics in historical use of psychedelics, at least. And the psilocybin in particular is found on all continents and is actually at least 9 indigenous groups in Mexico have been found to use it. There's artifacts here I have up here from centuries ago, I believe. So we're talking in the modern methodologies of these trials, but we owe a great deal from these ancient shamanic practitioners, as well as the set and setting variables that we know are so important in promoting positive therapeutic experiences within these medical studies. That all comes from these traditions. So most of you in here, I'm guessing, know what psilocybin is, but for those who don't, psilocybin is a serotonergic psychedelic that acts as an agonist at the subtype of a two-way serotonin receptor. It's very similar chemically to LSD. Actually, serotonin, it was actually the discovery of psychedelics and LSD helped actually to discover, was sort of pave the way for the discovery of serotonin. And for those, I tend to put this slide in here. I work in a drug abuse research facility, and there are some skeptics about, this like the value of giving a psychedelic, giving a drug to a vulnerable population, and the harm potential or the risk liability. So just a quick note here, David Nutt, who I think is actually going to be speaking at a webinar next month or so, he wrote this seminal article rating the harm potential of all drugs of abuse. Alcohol's on the very far left, psilocybin mushrooms on the very far right, and there were several metrics of harm risks that they used, and psilocybin's on the lowest. Okay, and so I mentioned the traditional sacramental use of psilocybin, and there are many other psychedelics that have been used in ritualistic and still are in some cultures, indigenous cultures, First Nations cultures. But in the sort of modern era, the modern historical era, in the 60s, there was a lot of research. Over 40,000 research participants volunteered for studies, mostly with LSD in the 50s and 60s. The primary indications were actually alcohol addiction, and the second highest was end of life distress. So the studies that we, these psilocybin studies that we are doing today very much draw on the knowledge base that was developed back then, mostly at Spring Grove, Maryland, where Bill Richards, who's still practicing, and Stan Groff, for those of you who are familiar with those names, they administered hundreds of LSD doses there to people who had cancer and other life-threatening illnesses and terminal illnesses, and a lot of preliminary data came out of there. And also just want to mention that this idea of a peak transformative experience, often spiritual in nature, goes way back, goes probably back even further in religious history, but William James, the father of psychology, recognized the value of a peak experience, as well as Abraham Maslow, father of humanistic. In the modern era, Roland Griffiths, who is one of the pioneers in the in modern clinical trial methodology, he published this paper in 2006 with his team at Johns Hopkins, and gave psilocybin, few doses of psilocybin to healthy volunteers, and basically found that psilocybin produces very highly spiritually salient, meaningful experiences likened to a mystical type, very, experiences that you would sort of hear about in scriptures, and used validated scales to measure and to capture these mystical states, as well as these meaningful ratings of meaningfulness. So that's important, as I'll talk about for this population. And as Peter mentioned, I think he talked briefly about the default mode network. It's hard to give a talk these days and not mention the importance of the default mode network when it comes to understanding what psychedelics can do in the brain, and then psychologically that can be therapeutic across several different diagnostic categories. So what we know, and it's pretty well replicated finding. What's interesting is I also put up here a slide that a picture not just of the brain under psilocybin, but a brain under the influence of a certain type of meditation called open awareness meditation, which is sort of in the non-dual tradition. The brain is the activations that we see here and deactivations. There's this disruption of the network called the default mode network, which is active when typically when we're during rest, during mind wandering. It's associated with mind wandering. It's associated, it's hyperactive in folks with depression, anxiety, substance use disorders, and I believe cancer-related anxiety would fall into that same category. Really high, seems to highly correlate with perseverative cognition, ruminative thinking. We get these kind of stuck in these thought loops, and we think psychedelics acutely disrupt this network in the brain and loosen these networks in such a way that bottom-up information from limbic systems, from emotions can come in into consciousness, which otherwise would have been blocked by this top control mechanism from the executive functions. And a metaphor on the top here, a snowstorm. I like to use this metaphor of a snowstorm. This is not my metaphor, it's Mendel Kalin's Imperial. It talks about how psychedelics seem to be like the dropping of snow on this mountain that has well-trodden ski paths. I was a skier at one point. I'm clearly not these days, as you can tell. But the trails that were well-trodden trails, if you have a snowstorm, those are all gone. So the routes and the patterns of thoughts that we otherwise would be using and throughout our day and get kind of stuck in, there's an opportunity to go down new paths, forge new paths, and then the brain is also communicating in different ways. So that parts of the brain that otherwise aren't communicating are communicating, or weren't communicating now are. Let me just quickly check the chat. I think I saw some. Maybe not. I'm going to keep going unless there's anything super burning. Okay. So that's a very crude summary of some complicated brain activity that takes place. But yes, you can have access to the slides. Yes. Okay. All right. So next. So this slide here, I don't want to spend too much time, some more complicated brain neuroscience, but I have some data here on the right that is that I'm excited about. In addition to this relaxed beliefs that we think is happening, default mode networks relaxing, these patterns of thought that otherwise would be kind of rigid and constrain our thinking and getting stuck into these ruminative cycles. With that relaxed sort of belief system, relaxing the influence of prior beliefs on the present, we also think that that there's a greater access to positive information in one's consciousness or in one's sort of sphere of awareness. And so I don't think I'll have too much time to talk about this, but we're seeing here in a recent paper by my colleague at Hopkins, Fred Barrett, finding this increased activity in this part of the brain called the medial orbital frontal cortex that is now coming online, or is active during an emotional conflicting task. And we see here in my study that the participants after an ayahuasca experience are increasing in their dispositional positive affect. So like as personality sort of traits are increasing and more sort of positive, they're more oriented towards positive stimuli. And then before I move on to describing the studies, I want to just share my kind of final sort of hypothesis for why psychedelics seem to be helpful. So with regard to sort of the default mode network, these relaxed beliefs under acute influence of psychedelics or psilocybin in particular, seems to promote this sort of psychological zooming out we see that it can facilitate psychological distance from these sort of rigid appraisals of oneself in the world. And we then experience the state of meta-awareness. So these appraisals that we have about ourselves then become kind of diminished, like dialed down, and then we can sort of transcend this. So the self-transcendent state is a way of sort of thinking about how when we relax the brain mechanisms that are typically in place that constrain our cognition so that we can do our work and focus on things and survive. If we get a little break from that, we can actually become aware of other pieces of information. So for a cancer patient, and we'll talk more about, cancer can become so narrowing of one's consciousness. You get so, it can be so hard to see anything beyond that. So what can happen with psychedelics is that we get this break from that, and we're able to reappraise the context in which we're in. And as a result, we experience more positive emotions, self-transcendent positive emotions like awe, love, gratitude. And we're able to, instead of avoid the emotions that are hard to experience, we're actually able to develop healthier emotion regulation strategies like reappraisal. And then once we do that, we're able to incorporate new data, contextual data, that then helps us feel a sense of a greater meaning in our life. And then that can reduce existential anxiety. And I'm going to illustrate that with some quotes in a little bit. I'm not going to spend too much time on this, but essentially what happens here, I adapted this slide to show that with cancer, any sort of depression, negative beliefs, we can get focused on only the negative things. But when we broaden our attentional field, we can encompass more. So it's not that we're getting rid of the negative. It's not Pollyanna-ish. We're not trying to say that everything is, everything's good, this positive mindset. It's more that it's a holistic mindset. Okay, so in 2016, we published a study that we co-published with Johns Hopkins, and this was a small study, but we had a control arm. We were able to do a control arm, and I'm going to show, I think I'm just going to go to the next slide just because this shows a little bit more of what it involved. We had two groups, a crossover where every group had one dose of psilocybin, one dose of the placebo niacin, and then crossed over. So the folks who had the psilocybin first got the niacin, which is a B vitamin, they got that second, and then vice versa. And there was a lot of therapy before, in the middle, and after. And then we measured anxiety, depression as the primary variables, as well as these other existential distress and quality of life secondary measures. This is what the room looked like. It involved every participant had two therapists, and they laid down on this couch for most of the day. It was an 8-hour session. They were able to listen to music, directed their attention inward. Psilocybin usually produces kind of like a dreamlike internal experience, and can be very sort of emotionally and visually vivid. So not much talking takes place this session, but afterward. And the primary outcomes were depression and anxiety. And as you can see here, this is the pre-crossover. I know I'm going kind of fast here, but I can answer more questions if there are about the design. But up to the 7 weeks, we were able to see this between groups. So the blue is the control. So they are getting a little better, but not as much, and they're kind of recovering. In the psilocybin group in the purple, they are definitely reducing. There's a real reduction, and they're kind of staying low in anxiety and depression. And then we did find actually that the mystical experience, MEQ, which measures like the spiritual mystical type experience, mediated, so explains the effects on the sort of relationship between psilocybin and control on the primary outcome. So there's something about this mystical type experience that is important. And then 4 years later, I re-administered, so I conducted a secondary study, and we looked at everyone who was still alive. So about half of our population passed away from some of the cancers that were later stage. And we actually got a nice press coverage. This was last year. And we re-administered this primary measures and some of the secondary ones 3 years and 4 years after their psilocybin sessions. And we see here pretty remarkably, we were not expecting this, just that with very large effect sizes, that the results seem to persist. And these are the groups combined. So at this point, everyone had this, both psilocybin and the control after that 7-week crossover. So we can't totally tell, it's not a true, we can't really conclude that the psilocybin, if we had two groups that never had crossed over and both groups had just received one treatment, then we would be able to create comparisons. But this is a pretty strong suggestion that some psilocybin is helping. Continue to have response and remission rates that were very high at this 4.5 year follow-up, which is pretty impressive. So 80% continue to endorse depression remission. And then also at this 4.5 year mark, continue to rate these at the top 5 or single most spiritually significant. 100% said positive behavior change that they can still continue to experience at this point. So enduring positive benefits. And then just quickly here that we see here that there's an interesting relationship between time and hopelessness and depression, that actually the more that time passes, the more that people are continuing to get better. So presumably, in several years from now, there actually would be even more of an effect, is what this is suggesting, that more time passes, more they're getting better, like the better they're getting. Instead of the effect that's like diluting after just one session of psilocybin, it's actually getting stronger. And then just this last set of data that I'm presenting is, we just published this like 2 weeks ago. We went back to the data, we created like a composite of suicidal ideation from one of our depression scales, and basically found that we didn't have enough power. We only had a sample size of 11 for this analysis, but we see here that there's a very strong suggestion, and there's a within group reductions. I won't get into all the details of the between and within group, but there basically is an effect not strong enough to show that the between group, that there's a between group effect, but we're seeing that psilocybin might have anti-suicidal properties. Okay, so now as I wrap up, I'm going to just present some qualitative data, which is probably my favorite part of my favorite research projects that I've worked on over this course of these past few years. So one thing, there's so many quotes I could have chosen, but I chose these quotes. These quotes really illustrate how this type of intervention is very different than traditional therapy, like cognitive behavioral therapy, or even many other types of talk therapy that don't have the same type of, and this is not a somatic therapy, but there's something about these experiences that are very powerful. And as Augusta said, these are all de-identified names. These are pseudonyms. So it wasn't like talking about it, which makes it an idea. It was experiential. There was a feeling beyond an intellectual feeling. There was a feeling to the bottom of my core. And then I'll actually read Mike's at the bottom. And he speaks to how these are different than antidepressants. It was an intense struggle. And that's where it became medicinal, because it allowed that struggle to happen. It didn't code it. It wasn't an antidepressant. It brought it all out. So as I was saying with the default mode network, if we relax that sort of control tower, if you will, we get these motions come up. And there is it can be overwhelming, but it's actually this sort of experience of emotion that otherwise maybe would have been avoided. I see a question from Henry. Oh, thanks for asking. How do you measure loss of meaning or existential distress? We measured I don't know if I have it here. So we have a spirituality measure that is called the facet, but we also, for this study, we created a loss of meaning composite factor from our demoralization scale. So we had a demoralization scale by Kassane, who's the author of that scale, but we created our own. We created our own basically composite loss of meaning, and I didn't have space or time to go into all the methods of this study, but that is a great question. Okay. Oh yeah, the dose of the study. Yeah, I'll answer this question quickly. So we gave 0.3 milligrams per kilogram. I don't know if I put that on here. Yeah, so we did 0.3 milligram per kilogram of psilocybin, and there was 250 milligrams of niacin. And there were 2 sessions, but only one was psilocybin. So they all had psilocybin and the control. That was, sorry, here. So as you can see here, they have, they all have, yeah, they all get psilocybin, they all get niacin, but in reverse order, and then there's all this therapy in between. And here are some more the assessments. So yeah, but the existential distress, we don't say it here. It's a functional assessment. I forgot the acronym, but it's for serious illness, existential sort of distress, and then demoralization. And then we have, I'll just have 2 more slides about, I think 2 more slides about the quotes. So cancer was no, so this, I call this psychological uncoupling from cancer. So what was interesting is that for many people, cancer did come up, but others didn't. And for some, they noticed that where the site of where they held the site of their cancer, so where it was like for Chrissy, it was in her abdomen, or it was like she had a stomach, I think she had, no, not stomach cancer, she had endometrial cancer, I believe. So she said during experience, I didn't feel like it was cancer related. It was more related to anxiety and I care, or I think I meant to say that I carry in that part of my body. So she, for her, kind of realized that the cancer was sort of, holding a lot of its emotional, unprocessed emotional pain. And for my cancer was nowhere in evidence. If anything, it was part of that same smoky, shadowy chaos of anger and fear. And a poetic quote here from Erin, one of the vivid images that I had was a sketch of a dinner table. And at that table was cancer. And it was supposed to be there. And the feeling I had was cancer is a part of everything. It isn't this bad, separate thing. It's something that's part of everything, and that everything's part of everything. It was an acceptance. So, and I'll just share this connection from disconnectedness to connectedness. That's a lot of sort of emerging theory, psychological theory about connectedness with psychedelics. So Augusta felt like she belongs. I see myself connected to everyone and everything. And as Erin also said, you feel like you're part of something. We're all connected. And I don't want to say anything else about that. I guess I'll just say that there's interesting insights around cancer for people. So would I be orally? It was oral. It was all oral pills. Psilocybin administered. So going back to that Viktor Frankl quote about between the stimulus and response, there's a pause. There's this pause. Is I think really this experience of being able to uncouple these this sort of process, this emotional process from their cancer. And I like to think of this as cancer, is not a threat to their lives, and maybe a threat to their physical lives, but it's not a threat to their, not a threat to their identities, not a threat to their sense of who they are. sense of purpose in life. And so and for many people, they experience like an ego death, and I thought of it kind of as or labeled it as like a death rehearsal, and realized, oh, it's not as scary as I thought, and where actually death anxiety went down for many people. So this sort of reappraisal of cancer and the threatening sort of nature of cancer. And then to wrap up, limitations and future directions. So these studies that I talked about were part of a phase 2 trials to get through FDA. There's a number of breakthrough designations that a couple of or 2 organizations have received with psilocybin to study this at the phase 3 level. After phase 3, then we'll then be hopefully apply to the FDA to get these medications rescheduled and used legally within medical settings. So one of the big limitations in these studies is diversity and inclusion. I'm skipping around a little bit, but over 82% of the participants in our study were white, mostly male, white, affluent. So, and the people who do really need these I would say the most vulnerable populations are not being included in these trials. So that is a problem. So that's a very large limitation of these studies. We need more controlled longitudinal studies. So that's kind of basic. But I also think on a more, my bias and what I hope will come from these studies and from this work is that the insights that these participants and that people have who are touched and moved by psychedelics, that it will be it'll help to integrate that we'll be able to integrate these experiences in ways that goes beyond the individual self. And during this integration process, how can we help be of service to the world? How do we bring healings not only to ourselves, but share this to the world and communities and really better our planet? And then lastly, reciprocity. The wisdom we receive from mostly indigenous populations who have worked with these medicines for hundreds, maybe thousands of years. I hope that we can, as this work becomes more and more commercialized, that we'll be able to incorporate them into this, or at least acknowledge their contributions. And here's a picture of the NYU team. It's much bigger than this, but I was only able to find these questions. We only find these photos, and that is it. And I'd love to take some questions if there are more.
All right, Ilan, we might take the slides off the screen so that we can see faces and actually realize we're human beings on this call. Great. Gabby, thank you very much for that presentation and the work you're doing. The gift that this medicine gives to people in those trials is extraordinary at a time when people are very vulnerable. People on the call may know that we've sought to reschedule the psilocybin in Australia for use as an unregistered medicine by psychiatrists and specialist addiction physicians. That was knocked back at the interim stage by the TGA. And then we went back with a much fuller analysis of every argument that the TGA used. And that's in turn led to an independent inquiry. So we're hopeful we may actually see these medicines being rescheduled in the next few months.
Right.
But the reason I give you that background is that in our submission to the TGA, which is available on our website, there's an appendix from a very brave Canadian man called Thomas Hartle, who was the first person in Canada to get the benefit of legal psilocybin-assisted therapy. Thomas has got stage 4 cancer, and in his letter, which is Appendix F, he relays the importance of this therapy to him. And one of the comments he makes is that, I'll just read briefly from his letter. when you have a terminal illness, hearing talk about studies that may or may not produce any outcomes in 3 or more years time is equivalent to saying that nothing can be done for the rest of your life. In Canada, they seem to have overcome that issue by the Canadian government giving exemptions to medical practitioners to use these therapies for people as part of end-of-life therapy for depression and anxiety. Gabby, when you're looking at this as a trial clinician, the researcher always wants more and more data. But at the same time, we've got people now who are going through all the pain and suffering that you relate in your presentation. Do you think the Canadian approach is the right approach, that government should be stepping up and giving exemptions to medical practitioners where they can establish a case for a person because they are probably in the last stages of their life and suffering from depression and anxiety?
Yeah. So my personal opinion, yes, as a clinician, absolutely. I mean, I think we have it's a more limited pathway, but we do have compassionate use, so it takes a little bit of time to apply for it, but we can include in some of these trials participants who otherwise wouldn't be eligible to participate. And we were going to apply for a compassionate sort of waiver for someone who is going to pass away within 3 months. And our criteria has to be at least a 6-month life expectancy. And then unfortunately it didn't work out for that participant. But that goes without saying that I guess if I do think that the research is not moving quickly enough. And I do think sometimes we spend, as someone who's both a researcher and a clinician, I get very, very frustrated by the bureaucracy, the red tape involved in the research that I find can be, the research is very, very, is what we need the research, but we need the research to help get these medicines rescheduled. But I think from an immediate impact perspective, it's not helping the people that we're trying to help. So it's a tough subject, and I get contacted all the time, and there are people who contact me, and I don't know how to respond because the studies are also very hard to get into. They're sometimes very hard to travel to for people who don't live nearby. And so yes, I think from a clinical standpoint, and especially with these medications, we know that they're safe. We know, the harms are really, when it comes to the harms are really relate more to the psychological risks when done in a way that is not therapeutically supported, or not but otherwise they're safe. So I think we know that, and if we can get them into the hands of the people who need them, and find a faster route to do that. So some of these breakthrough designations that we have here in the US are sort of an attempt to do that. And then of course, then there's these underground practitioners that everyone can, they exist, but it's hard. They're not regulated. It's wild west kind of out there. But for people who really do want this, they can find that. It's hard. I wouldn't recommend it to people, but yeah.
Yeah, I mean that is the issue, isn't it, with underground therapy, because you've got no quality control, and I've no doubt there are some fabulous therapists out there doing it, but with no quality control, and by definition very vulnerable people. It's not a great mixture, is it?
No, it's not. It's not. And I don't know, Peter, if in Australia, if ketamine is being offered, or what the legal framework is, but ketamine is being used here as a psychedelic, And in a similar way, I'm being kind of incorporated into therapy practice within a kind of similar psychedelic model. And there are pros and cons to that, but that's one thing that I'm able to recommend to folks who are seeking a psychedelic like experience, and it can be sort of within a container, but also those are very expensive. Insurance doesn't cover that.
Yeah. I mean, people are just making the comment on the chat line that.
Yes, let's look. I'm going to turn on my light actually while you.
People,
okay,
just say,
so
people making the comment that ketamine is available.
Interesting. Okay, educating me about Australia. Let's see, interesting place. It started to be used by some off-label psychiatrists. It's expensive, yeah. Yeah, unfortunately. Yeah, I mean, for anyone who, BIPOC folks, it's just, I think any of these treatments, unless they get into a study, but there's a real bias towards just white, or just the recruitment efforts have really not been engaged with community efforts to really bring in folks who otherwise are not going to be able to afford these. These ketamine here in the Bay Area, it's thousands of dollars, and ketamine is very cheap. It costs very cheap. It costs nothing. So it's just the system is we're trying to sort of calibrate, and black market is cheap. But it's it's hard. And I do know that there are a lot of good people who are working with insurance companies, with some of the people with MAPS who are trying to help solve this problem and create more structures, a culture around this, so that it doesn't fall within the sort of capitalist same model of medical kind of model that is
Gabby, that question from Jody Rosenberg, just above the ketamine.
Were there any Jody Rosenberg? Okay. Were there any other? Sorry about the light.
You have a halo around you.
A halo, yeah. Were there any other mediating factors tested for in the trial other than MEQ? So we only tested MEQ. Did we do some correlations with other? No, that was the only one we tested for. But interestingly, at the long-term follow-up, MEQ did not predict the long-term scores. So only in the short term, only that's 6-week mark did we see that MEQ. And I have some interesting bias. Not that I don't believe the mystical psych experience is the thing. Not that I don't think it's important, but I think there's more that we're not capturing. And I've been testing other models like reappraisal and other mindfulness kind of related mechanisms. So I think spirituality is important, but not for everyone and not for certain populations. So I think then we're moving into we're developing newer models. Psychological insight is another one we're looking at, and emotional breakthroughs. So those are some other mediating factors that are being tested now. And then were participants psychedelic novices? About half of them were. I actually didn't put that. I could throw. It's not worth it. But about half had psychedelics at one point in their life, but most of them had not had it in several years. And I think that might have been a criteria, eligibility. I think we might have had. A lot of these studies will allow participants hallucinogen experience or psychedelic experience, or people who have experience, but we'll have to have waited several years or 5 to 10 years. But I think for ours, it was it was definitely half had at some point. Let's see if there are other questions. Oh yeah, go ahead, Peter. Were you going to say something, Peter?
Well, no, that last question, by the way, is one that's deeply personal to me, because my wife before Tanya died about 10 years ago and died from stomach cancer, and went through a terrible process, dying process. And I keep thinking that had these therapies been available, it could have made a big difference. But I'd not focused on this issue that's been raised in the question about whether somebody with stomach cancer can still get the benefit of this.
You come across any patients with stomach cancer? Oh my gosh. Well, I spent a lot of time in the cancer center when I was working in the city. I mean, stomach cancer is one of the most upsetting. It's such a hard, not all cancers are, but stomach cancer. We did not have stomach cancers. I honestly think that it might have been an exclusion, or it may have been like an indirect exclusion for needing to be able to metabolize the drugs. So psilocybin is an active molecule, becomes psilocin. So psilocin would need to be metabolized. So I think that would have been an exclusion, or depending on the how severe the cancer was at that stage and which organs were affected.
Yep.
Yeah, we couldn't inject. We didn't use it, at least for this study. It had to be standardized for oral. But in those early studies at Spring Grove in the 60s into the early 70s, before the Controlled Substance Act prohibited the use of these drugs, the participants in those studies were very late stage, or pretty much like on their deathbed. Apparently, Aldous Huxley asked his wife to give him LSD on his deathbed. So it's from a safety perspective. They're anecdotally, it's been done at like late, very very late stage.
I suspect a few of us have got that request, by the way.
I mean, it's something else. I mean, a lot of people, morphine, like you just want to like not be conscious, but like to be that conscious is something it takes a certain type of person. But yeah, it's I mean, there is a lot of early work with LSD and cancer patients was done by Eric Cass at Chicago, University of Chicago, for pain relief, actually. And but for these studies, we unfortunately can't. We just don't do that with late stages. Very, very, or we don't do it with like severe organ damage affected cancers.
All right, look, I'm conscious of the time, so Elaine, you might just put on the final slides. But as Elaine's doing that, I might just say, Gabby, it's been a tremendous presentation, and it really sort of drives home to me why we have such urgency in getting these medicines rescheduled, because there are people out there in pain, and we have an unregistered medicine framework in Australia, which will enable these medicines to be more available if the medicines are rescheduled by the TGA. And behind that decision, there are not only a huge number of people suffering from depression and anxiety and other illnesses that could be treated, but there are people who do have stage 4 cancer or are otherwise terminally ill, who could be given an extraordinary gift in the last parts of their lives. And I do think it's incumbent on all of us to do everything we can to make sure that that gift becomes available in a legal environment where the people can be treated safely and with confidence.
Yes. Well, thank you for the work you're doing.
One of the things we do that people may be aware of is psychological support services, and that enables people who are intent on experiencing the medicines to get psychological support both before and after. And that's something that's intriguingly consistent with government policy, although the actual taking of the medicine is contrary currently to government policy. And that's now a network of psychologists and psychotherapists right across Australia. So people on the call in Australia should just be aware of that. And that's also expanding into New Zealand. Next slide, Elaine. I think many of you will have seen this comment of Tim Ferriss, but it really does explain to me an awful lot that we have a chance here of shifting a paradigm. And if we can shift the paradigm, then the mental health system takes over. So for relatively small amounts of money, there's an ability to really change Australia, indeed the world, but obviously the focus of My Medicine Australia is on Australia, by offering healing to so many people. Next slide, Alan. For those in the course, how you can help. Again, particularly if you're in Australia, start conversations, build awareness, let people know that this is serious. It's something that can be made available through trained therapists, and it can make an enormous difference in our mental health statistics. And we're only suggesting it as an option, by the way. We're not saying that this should be for every person with mental illness or for every medical practitioner, but there should be an option in our mental health system providing for these therapies. There's also there's a few questions came through on the chat about volunteering. Go to our website. Yes, we enormously value, as a not-for-profit, we enormously value the input of our volunteers. There's a massive amount of information on our website about these therapies. It's carefully curated to make sure it's objective, and it really distills what is a huge amount of information that's out there on the web at the moment. Fundraising or donating to us is incredibly important because, as I said at the start, the more leverage we have, the greater the chance of bringing in these therapies in the fastest amount of time, and then rolling them out across Australia in a really safe and regulated way with therapists and medical practitioners who've been properly trained. Again, if you're in Australia, talk to your local MP. There's nothing like constituents talking to a local MP to get the local MP focusing on new modalities. And finally, we have a summit that's scheduled for November 2021, pandemic willing. We've got an extraordinary group of people who are committed as speakers to that summit. And it really will be a hallmark, I think, in Australia of changing the psyche in this country to one that embraces these therapies. Next slide, Elaine. That's our certificate in psychedelic-assisted therapies. As I mentioned at the start, we're coming towards the end of our first psychedelic-assisted therapy course. We've had fabulous feedback from the participants in the course. And the whole intent of the course is to really overcome any arguments of regulators that, yes, these therapies look really prospective, but we don't have trained therapists in this country to provide the therapy. It's going to be a massive task as these therapies become legal to make sure that we have enough therapists around Australia to provide these therapies. So for any therapists on this webinar based in Australia who are interested in formal training, again, go onto our website and you'll see the link to the CPAC course, the Certificate in Psychedelic-Assisted Therapies, and follow the link and make contact with us. The second intake in July now is virtually full. We're planning 4 intakes for next year. Each intake is about 50 practitioners. Next slide, Ilan. We've talked about the summit, but again, go online to see the extraordinary group of people that we've put together. Wonderful thing I find about this sector is that practitioners in the sector, researchers, people like Gabby are very, very happy to give time because they believe so strongly in the work that they're doing. And at My Medicine Australia, we get inspired by people like Gabby and others who are really leading the research effort to educate and develop these therapies. Is that the last slide, Elaine? Yeah, just upcoming slides again. You'll see these on our websites, but really spread the word. What we'd love you to do is, speak to 2, 3, 4, 5 other people who you think might be interested. So we're constantly building awareness about these therapies and making people realize the high caliber of the researchers involved in developing these therapies and the high caliber of the research that's coming from those from trials and other research that's being done. Gabby, it's been a real pleasure hearing you and seeing you in action with the talk about psilocybin for end of life. It certainly inspires me, and I hope it inspires everyone else on this call to make sure we do everything that we can do as individuals to fast track these therapies, particularly important for people with end-of-life distress. It's an amazing gift, and it's fabulous seeing the growing momentum that we've got in Australia and around the world, and the fact that the prejudice associated with these substances is increasingly starting to crumble, and it won't come too soon. So thank you very much for being part of this, Gabby, and thank you all for being part of this call and being part of this this amazing movement, which is such a gift for the planet.
And thank you, Gabby, also for me. It's Tanya.
Tanya, it's good to see you.
Yeah, I'm at the certificate, the intensive week for the certificate of psychedelic assisted therapies. It's our final week, and we're going to have 50 graduates, and I think you're speaking to them tomorrow.
Yeah, tomorrow. Yes, I'm excited.
Fantastic group.
We just had Dr. Gabriel Matte talking about addiction, so it's been
oh, amazing.
It's been some fabulous lecturers.
Wow.
All right, well, with that, I might close the webinar, but again, thank you for all for attending and being part of this fabulous movement.
Thank you so much.
All right, thank you very much, Gabby.
Care.
Bye-bye.